And here you can see some nice little alveolar sacs scattered through the lung tissue. This is nice, normal-looking lung. Now, believe me, if this was that old guy with the chronic bronchitis, he's always going to have a lot of emphysema as well. You can't ever separate those two diseases. Chronic bronchitis, emphysema. We lump them together because they're always together, and we call it COPD, chronic obstructive pulmonary disease. But this is a nice normal lung, looks really healthy. The person that had emphysema, what happens is a lot of these walls between these alveoli just disappear. They just get destroyed by the disease. And so instead of having a whole bunch of nice little alveoli like this, they might have big cavities in their lung where all the alveoli have been destroyed. And obviously there's not near as much surface area in a lung like that to absorb oxygen. So these old guys are breathing like hell just to stay alive because they don't have enough good functioning lung left. I think I've talked about this enough. Let's just talk about the cells a little bit. There's basically very few cells down here. There's the main type of cell is the type 1 pneumocyte that makes up most. It's a simple squamous epithelium that makes up most of the wall of the alveoli. And all of these cells here are going to just be having oxygen and carbon dioxide diffusing straight through them. Because connected to every alveolus and going all the way around the alveolus is a whole bunch of these little capillaries, which you see here. So here's one alveoli that has 1, 2, 3, 4, 5, 6 different capillaries going around it to pick up the oxygen. We'll talk about the membranes between the two. So that's type 1, pneumocytes type 1. These are the pneumocytes type 2. Pneumocytes type 2 are very important because they make a substance that dissolves out and spreads out over the surface of these alveoli called surfactant. Surfactant is a protein that lowers the surface tension, so it allows the alveoli to stay open. And if any of you ladies ever had or had a friend who had a premature baby, a lot of times the issue used to be the thing that killed premature babies was always their lungs. And their lungs just weren't mature enough to keep the baby alive. And so one thing they learned was that a monitor they could use for that was the surfactant level. And if they would do an amniocentesis, stick a needle into the amniotic cavity, draw some fluid out, and measure the surfactant level of the fluid. If the surfactant level was up good enough, and say the baby had other problems, they could go on and get the baby delivered, and the baby they could figure would probably do okay. On the other hand, if the surfactant level was too low, back in the day, they used to leave the baby in for absolutely as long as they could and let it mature inside mama's womb until its lungs matured and they had enough surfactant to then be delivered, hopefully. We can now make surfactant. So we can produce surfactant and we can give it to babies in a breather, in a ventilator, and help them out. Give them the surfactant that they need even before they can make enough themselves. And it has lowered the mortality of immature lungs in babies, which has a name. Anyway, so here's kind of a list, but please don't worry about it. Just know that the respiratory bronchioles, the alveolar ducts, are really, these guys, all three of these are really the last, are really just alveoli. Oxygen is being absorbed from here down. Okay? Let's talk about that alveolar epithelium that we were just talking about a minute. And remember that most of it is just this simple squamous epithelium, which is called, those are called pneumocytes type 1. There's always some alveolar macrophages, also called dust cells, that are going around eating up anything that survived the trip from your nose down to the alveoli. Usually they've been filtered out or they've stuck to the side by the time they get that far. There's also these pneumocytes type 2 that I've already mentioned to you. I didn't realize that. They call them septal cells as well. But okay, they're the ones that produce surfactant. I did have that right. Surfactant is this oily stuff, a bunch of lipoproteins. It coats the surface of the alveoli on the inside, and it allows them to pop open and stay open. Kind of like bubbles, kind of like soap bubbles.
Is that what happens in premature babies then? They just don't have that?
Right, and their alveoli just collapse.
Their bubbles pop.
And their bubbles, no, they don't pop, they just collapse on themselves. And you know, you can ventilate them, you can put positive pressure, PEEP, positive end expiratory pressure, trying to keep those alveoli open, but sometimes you just can't do it. And they really do need the surfactant to help them out. So let's talk about this respiratory membrane, because this is really where it's at. And I think I told you the other day that one of the things our lungs provide for us is a surface area about as big as 2 tennis courts in our lungs. That's what we need in order to absorb all these gases and get rid of all these gases as they go down through, as they are made in us. There's basically 3 layers to the respiratory membrane. One is the squamous cells, these little squamous epithelial cells that are on the inner lining of the alveoli. Those are the ones that confront the air on one side. Then there's an endothelial cell on the other side, which is one of those capillaries that we saw, and they're just kind of covering the whole thing. There's lots of them that are full of blood on the other side. And then between those two, where the alveolar cell and the blood vessel cell come together, there's a little basal lamina, a little basement membrane, so to speak, which is very, very thin, and it fuses those 2 layers between the alveolar cells and the endothelial cells. Now, this is a schematic of that. Yes, ma'am?
And so the capillaries diffuse across that basal.
The what?
So the blood diffuses across that.
No, the blood doesn't. Hold on.
Okay.
Watch what I'm going to say here.
Okay.
Okay? Good question, but... All right, so here is, here's the alveolar airspace out here. This is the pocket of air on the bottom side of this little diagram here. And then, so this layer here is that thin little tiny flat squamous, simple squamous cell, the pneumocyte type 1. Right? Just above that is this little fused basal lamina, which is basically just holds these 2 together. It holds the endothelial cell. This is the tiny little, also a squamous, a simple squamous epithelial cell. But it's an endothelial cell, which means it's the inner lining of the blood vessel. But remember, these are such tiny blood vessels, they're only 1 cell layer thick. Okay? So here's your endothelial cell. And occasionally on both of these, you're going to see a nucleus every now and then. They've thrown a nucleus into this picture here. But if you follow this out far enough, you'd probably see a nucleus of this alveolar cell as well. So here's the 3 layers. And there's the alveolar epithelium, the fused basal membrane, and the endothelium. This is blood. This is plasma that I'm pointing in right here. And lo and behold, there's this big old huge red blood cell rolling by, coming through those capillaries. Okay? Now, the red blood cells are really important because they contain all the hemoglobin, right? And the hemoglobin is what is going to grab onto that oxygen and carry it around the body. So, it's important that things be able to diffuse through these things pretty quickly. Because think about what I just said a minute ago. Your entire blood circulation is going through those lungs. And it's going through them pretty fast. And in the time that blood passes by up here, you've got to hope that there's oxygen that somebody's breathing, and so there's new oxygen in here for that oxygen to work its way across, get into those red cells, and be taken back to the heart. And that's exactly what happens. It happens very quickly. The blood isn't in these capillaries for more than 3 to 5 seconds at the most, and in that 3 to 5 seconds it's picking up oxygen. It's also giving off carbon dioxide as a waste product. Okay? So, this diffusion across this respiratory membrane is very rapid. It's very short. The distance is short. These are thin, very thin cells. And oxygen and carbon dioxide both are lipid soluble. And because they're lipid soluble, that enables them to get through this thing right here, which is, remember, the cell wall of a... What makes up cell walls? I mean, not cell walls really, but the cell membrane. Phospholipids. Remember that biphospholipid layer that you learned about back in 112? Well, that's about all it is. So it's lipids, and so it's important that the stuff that's going to diffuse through there has to be lipid soluble. Same with this on this side. They are. They're both lipid soluble, so therefore the gases can exchange very quickly. Oh. Did somebody leave their cell phone on?
No.
It's mine. It's mine. Okay, so when a lobule gets inflamed and it gets filled up with stuff, and what usually happens is it gets full of pus, it gets full of white cells, it gets full of fluid, because you know when things get inflamed they weep fluid. That's why you bump your hand and your hand swells, right? It's weeping fluid out into the area. It's one of the parts of inflammation. Remember, the most basic of all ways we fight disease. When it fills up with fluid, we call it pneumonia. That causes fluid to leak out into the alveoli, and guess what? If the alveolus is full of fluid, what happens?
It's not full of oxygen.
It's not going to be able to absorb any oxygen, and so the blood that goes through those capillaries isn't going to get oxygenated, right? So it's going to head back to the heart, not quite as oxygenated as it ought to be, because that area of the lung that it went through didn't have any oxygen. It was full of pneumonia. That's why people with pneumonia get sick, and that's why oftentimes they need additional oxygen. Sometimes they even need a ventilator to help them breathe. Okay. Have I said all of this already? Probably have. I tend to ramble. These slides keep me honest, though, so I know I've talked about most things. So here we go. Each lobule receives an arteriole and a venule. Respiratory exchange surfaces occur that receive blood from arteries of the pulmonary circuit. And there's a little capillary network around each alveolus, and blood from the alveolar capillaries passes through the pulmonary veins and goes back to the left atrium of the heart. Remember, the left side of the heart. Yes, ma'am?
Is the alveoli and the lobule is the same thing?
No, a lobule is a little piece of your lung.
Like a loop? A loop?
No, it's like a branch of a tree.
It's smaller than a lobe. It's like a piece of a lobe.
Little tiny piece of a lobe. Small enough that all it has is an arteriole and a venule. Arteriole going to it, venule going back from it. Okay? Now the second part of this, which I've already mentioned to you, I've already explained this to you, is that the blood supply to the lungs tubes, that's my name. The book calls them bronchioles, bronchial tubes or something, bronchioles. But obviously you need the second blood supply to the lung, which is going to provide oxygen and nutrients to the tissues of the conducting pathways, to the tissues that make up the tubes themselves, okay? That comes from the bronchial vessels, which are arterioles that come right off of your thoracic aorta, and different other branches, but it's pure arterial blood, just like your radial artery or anything else out here. It's arterial blood. But on the way back, they don't go all the way back to the vena cava like all the rest of your blood does. They just dump right back into the pulmonary veins and go back to the heart. And so you're dumping a little bit of unoxygenated blood in with the oxygenated blood, but it's a very small amount and it only lowers the oxygen level 5 points. We'll get to that. We'll come back to that when we get later. All right. One of the problems with our lungs is because the blood pressure in the pulmonary circuit is extremely low. When you take your blood pressure out here in your arm, it's 120/80 millimeters of mercury. If you put a catheter into the pulmonary artery coming out of your heart, going to your lungs, the pressure is only 30/3. And sometimes it's 20/3 or 20/2. But that's all the pressure it needs because it doesn't have to fight much resistance to get into the lungs. And the pulmonary circuit is very low pressure, which is nice because it makes it easier on your heart. One of the problems, though, is crap can get into your pulmonary arteries and it can cause things to get blocked off. So, the pulmonary blood vessels are easily blocked by blood clots. We call that a pulmonary embolus. Blood clots, usually they form in your leg veins when you're in surgery and you're not moving a muscle, because every time we walk or step or move our legs or roll over in our sleep, we're squeezing the blood out of our calf veins and pushing them on back up to the heart. When you're laying there dead, paralyzed, having surgery, it's common for blood clots to form. And they get bigger and bigger and bigger. You don't even know they're there, and then suddenly they break off and people die of pulmonary emboli. I've got some stories about that later. Another thing that can happen is little pieces of fat. We see that mostly in multiple trauma patients. A patient gets involved in a car accident and breaks 4 bones, especially if they break their femur, the biggest bone in their body. The inside of the femur usually has lots of fat in it, and when you crack that open, that fat spills out, and that fat gets picked up by little capillaries in your thigh, and then the fat gets sucked off and goes to the lungs. And it just sits there in these pulmonary vessels until it gets reabsorbed. Sometimes it takes a while, and these people can get really, really sick and have really bad lung problems, even though their real problem was broken bones and trauma. If you're helping in the room where they're doing cystoscopy and looking up in people's bladders, and in order to do that, they kind of have to fill up the bladder with water. But what happens if somebody hooks it up wrong and they end up shooting air in there? Well, if they shoot air into the bladder, then that just gets blown right up into the veins, especially if they're doing some surgery and cutting the prostate away or something like that, and people get air emboli. If you have an open vein from a big incision and you suck air in, that can do you in also. That's called an air embolus. Air emboli are not a big deal unless you get a lot. It takes about 150 cc's of air in your heart to cause any problems at all. But it's kind of like, you guys ever had to prime a pump? You have to put water in the pump in order to make it so it'll pump. You probably never done any of that. But anyway, it's the same thing. Until you get so much air in there that the heart can't actually empty itself with blood each time or fill back up with blood, it works fine. But then all of a sudden it doesn't work and then you're toast. Yeah?
How does the body handle like air in?
Well, eventually it's going to reabsorb it. But remember what air is? Air is 79% what? Nitrogen. Nitrogen is very, very slow to absorb. So yeah, it will absorb, but it'll take a long time. And if you get enough in there, it can lead to those problems. Same with the fat. I mean, the fat will eventually reabsorb and go away, assuming you don't break your femur again or keep moving the pieces around where more and more fat keeps leaking out. That's why it's so important to stabilize the fractures and put people in a splint just to keep their bones from rubbing on each other. And as far as blood clots are concerned, the problem with these blood clots is they're so big, and they can start down here in your calf muscles, and the blood clot will extend and just be kind of floating there in the breeze, extend all the way up to your liver, and then they break off, and it completely occludes your pulmonary artery. Nothing can get through your pulmonary artery, and you're instantly dead. There's nothing that anybody can do about it. Yeah?
Does a pulmonary embolism lead to alveoli collapsing over time?
These three things here, really what they cause is problems with the circulatory system, problem with the blood flow through your lungs. Now obviously, if there's no blood flowing through your lungs, your alveoli aren't going to be doing much good for you. But these problems are basically vascular problems, not respiratory problems. Yeah?
How can we tell, they'll say like, oh, you had a pulmonary embolism and it passed through your heart twice. How can we tell that?
Well, the reason is usually the patients will feel really crummy. Oftentimes they feel pain, especially if the clot gets far enough out in their lung so it can actually kill off a piece of lung tissue because there's no blood flowing to it. But mainly the patients just look really sick and they have low oxygen levels, and you sort of figure it out. And you rush them down to ultrasound, and you ultrasound them, see if that's what's going on, draw blood gas, see if their oxygen level is really low. Then you usually you immediately put them on blood thinner so that no more clots form, even though there may still be clots there that can break off. It's a very, very critical problem when it happens. Dan Blocker, who's Dan Blocker?
He's in Bonanza.
Bonanza, Hoss Cartwright. Yeah, Dan Blocker was the big guy, the youngest brother on that crazy show from years and years. That was the first show ever in color, by the way. The first TV show ever presented on Sunday nights in living color on NBC. And Dan Blocker went to the hospital about 4 years into the show, I think. And he had his gallbladder out. Had gallstones, and back in those days they did that through an incision about this long, and so you end up getting a bunch of pain medicine. You end up laying around, and generally we did a lot of those as well through open incisions, and patients were usually in the hospital for 5 days, and usually for the first 3 days they were pretty much laying around, and you had to hustle them to get them out and make them move their legs and all that stuff. And so he was discharged. His doctor came by to see him in the morning, wrote discharge, and he was waiting on his ride to come pick him up to take him home, and he was walking down the hall and dropped over dead and could not be resuscitated. He died instantly of a pulmonary embolus. Today, we use all these kind of things that blow up and come back down. You have these leg squeezers, and you wear support stockings and all kinds of things to try to lower the incidence of this. In fact, most patients now receive a little tiny dose of blood thinner before surgery to keep them from forming.
My father had so many, when they finally did the scan, they saw a whole bunch in his lungs. And when the ultrasound tech went to see how far that went up, the minute the ultrasound went on his leg, another one broke off right in front of everybody, and he went down. There was no damage to the heart, but they said if one more goes, I mean, it's on warfarin.
Yeah, if you don't get too much, you'll recover from it, okay. Especially once you get on the blood thinner, then you're not going to form any more clots. But you don't want to put everybody on blood thinner because then they bleed from their surgery sites, and that's kind of a messy problem too. Okay, pulmonary embolus. We talked too much about that. Let's talk about the pleural cavities. The cavities are the little tiny, they're not real spaces, they're just potential spaces that surround each lung. They're separated by the mediastinum in humans. Each pleural cavity contains a lung. Oh, isn't that a clever line? And they're lined by the serous membrane. Remember serous membranes and mucous membranes? Serous membranes secrete a real watery stuff. It's serous fluid, yeah. But just enough to keep it greased up so that your lung can slide so that your visceral pleura can slide over your parietal pleura every time you breathe. It's so nice to be loved and have somebody that wants to talk to you. So anyway, there's parietal pleura and visceral pleura, and a little bit of fluid in between. Let me just say one point right here. That obviously, if you get a hole in your pleura, and usually the hole is from the lung, so that air gets out into the pleural space and causes your lung gradually to collapse, that's called a pneumothorax. Okay? Now, between these two layers here, between the parietal pleura and the visceral pleura, you can also collect a bunch of other stuff. If you get a bullet shot through you, it's going to fill up with blood, and we're going to call that a hemothorax. If it fills up with fat or lymph, it's going to be called, it's mostly water, it's going to be called a hydrothorax. So we'll kind of come back to those things, but just so you know that all kinds of things can collect in your pleural space, including pus, and then it's called a pyo, P-Y-O, thorax. Okay, respiration in us humans is divided into two parts, and let me just try to make this separation as clear as I can. The external respiration occurs from the lungs out. In other words, it occurs from the pulmonary membrane, the respiratory membrane out. Okay? And all of those processes that are involved in exchanging oxygen and carbon dioxide are what we would think of as external respiration, which we're going to go through in more detail here. Now then, the oxygen has been picked up by the blood cells, and it goes pushed out by the blood, and it goes, I always use the finger as the example of where the blood is going to go, right? Because your finger has got bone in there and muscle, it's got skin, it's got a whole bunch of tissues in there that need oxygen, right? So the oxygen goes out of the capillaries, out at your finger level here, goes into the cells out there, and we call that side of things where it's unloading the oxygen and where it's picking up the carbon dioxide, because your finger made a bunch of carbon dioxide that's gathered out there, and it's got to get back in the blood to get back to your heart. We call that internal respiration. Okay? Now, here's the big issue that confuses you guys, and I will make this as clear as I possibly can. There's another word that you've heard before, and it's called cellular respiration. Okay? Now, I would like to tell you that cellular respiration is really just part of internal respiration, because when you pick up that oxygen, it unloads off the capillary, goes out in the interstitial fluid, it goes into the cells of your finger, then it's going to go into the mitochondria, right? And you've got this wonderful process where you're making all this ATP. It's called the Krebs cycle. And all of that's cellular respiration. That's where you're actually burning the oxygen. So don't get cellular respiration confused with internal respiration.
Internal respiration is like more the transfer.
Is the unloading of the oxygen and the picking up of the CO2 in the periphery.
So is it fair to say that external respiration is pretty much breathing, and internal respiration is like systemic transfer?
Well, yeah, you can think of it that way, but remember, there's more to external respiration than just breathing.
Right. Okay.
You got to have blood flowing by there too, right?
Okay.
So 3 parts of the external respiration process that I just kind of answered for you there. There's pulmonary ventilation. Pulmonary ventilation is breathing. Okay? In other words, the act of doing is ventilation. Okay? We're going to go into this in more detail too. But that's pulmonary ventilation. Then there's also got to be this gas diffusion that's going to take place across those membranes And then we're going to have to find a way to transport the oxygen out and transport the carbon dioxide back. Okay? Let's talk about pulmonary ventilation for just a minute. Pulmonary ventilation is the mechanical movement of air back and forth. You know those machines that they have in the ICU that they hook up to people that have got a tube in their throat? What do we call those? Ventilators. Because that's all they are. They just pump air in and they let it come back out, or they suck it out if need be. Usually they just pump it in and out it comes. Okay? So those are ventilators, and that's what ventilation is. And if you want to help yourself right now, just know that fact. That ventilation just means moving air back and forth. Okay? Obviously, we breathe in a lot of air that doesn't even make it all the way down to our alveoli at the bottom of our lungs, right? A lot of that air just goes to fill up our trachea, and that air might come all the way into our trachea, but only get down to right there at the carina, and then it goes back out. Get ready for the next breath. So did that air do us any good?
Yeah.
No.
It kept things open though.
Well, but you didn't get any oxygen out of it. You couldn't use it to get rid of any carbon dioxide. We call that dead space. Okay, that's dead space. Because it's not really doing us any good. We'll come back to it in a minute. Okay, so to understand all this ventilation stuff, you're just going to have to understand some things about pressure. Because it all works on pressure. Now, and pressure is basically, they make it really simple here, it's just the weight of air, right? And there's a lot of important physiological effects of air. Okay. We'll keep going. Boyle's law is one of them. Boyle's law describes the relationship between gas pressure and volume. In other words, and I usually have a syringe with me at this time, but I don't today. If you take a syringe and you pull the plunger mostly out, and it's full of air, and then you put your finger on the end of it, you can push the plunger in, right? Oh, maybe you can even push it 2/3 of the way in, okay? So you have changed the volume of air inside that syringe. But in the process of decreasing the volume, what have you done to the pressure?
Increase.
Pressure has gone up. That's what Boyle's law is. Boyle's law says that pressure of any gas is inversely proportional to its volume. In other words, you can compress gas and make it more pressurized, but yet it takes up a less volume. So, why does it work that way? Well, think about if there were 10 molecules of oxygen in this box right here, and I closed it